cancer, a big blow. It's time to wipe off this foe. Let's run now and show. Let's get set and go. जिस आंधी जिस तूफान का डर है हर दिल में, उस कैंसर को जड़ से मिटा दे हम मिलके। चलो लड़ते हैं, चलो बढ़ते हैं, चलो दौड़ते हैं। Let's run together, चलो दौड़ते हैं, fight against cancer, चलो दौड़ते हैं। Let's run together, चलो दौड़ते हैं। कैंसर को रोके, खुशहाली फैलाए, एक उम्मीद फिर से हर दिल में जगाए। चलो लड़ते हैं, चलो बढ़ते हैं, चलो दौड़ते हैं। Let's run together, चलो दौड़ते हैं, fight against cancer, चलो दौड़ते हैं। Let's run together, चलो दौड़ते हैं।
Detect early, treat timely, eradicate totally. A global cancer awareness drive by Grace Cancer Foundation. Cancer Run
2023.
Let's run together. You gotta hit cancer, a big blow. It's time to wipe off this foe. Let's run now and show. Let's get set and go. जिस आंधी जिस तूफान का डर है हर दिल में, उस कैंसर को जड़ से मिटा दे हम मिलके। चलो लड़ते हैं, चलो बढ़ते हैं, चलो दौड़ते हैं। Let's run together, चलो दौड़ते हैं, fight against cancer, चलो दौड़ते हैं। Let's run together, चलो दौड़ते हैं। कैंसर को रोके, खुशहाली फैलाए, एक उम्मीद फिर से हर दिल में जगाए। चलो लड़ते हैं, चलो बढ़ते हैं, चलो दौड़ते हैं। Let's run together, चलो दौड़ते हैं, fight against cancer, चलो दौड़ते हैं। Let's run together, चलो दौड़ते हैं।
Detect early, treat timely, eradicate totally. A global cancer awareness drive by Grace Cancer Foundation. Cancer Run
2023.
Let's run together. You gotta hit cancer, a big blow. It's time to wipe off this foe. Let's run now and show. Let's get set and go. जिस आंधी जिस तूफान का डर है हर दिल
Yes, Harish, we can start now. It is live.
A very warm good evening, everyone, and welcome to another exciting webinar, Cancer Discussion on Colorectal Cancers, presented by the Grace Cancer Foundation. I'm Dr. Harish, a surgical oncologist and robotic surgeon, and I'm honored to be your host for today's event. So, colorectal cancer is a leading cause of cancer death worldwide, but with advancements in medical research and treatment options, there is hope for improved outcomes and enhanced quality of life for patients. Today, we have the privilege of hearing from a world-renowned expert in the field of colorectal surgery, Dr. Steven Wexner. Dr. Wexner is the director of Ellen Leifer Shulman and Stephen Shulman Digestive Disease Center and has been on staff at Cleveland Clinic, Florida since 1998. He was the chair of Department of Colorectal Surgery from 1993 to 2024, close to 3 decades, and is now the emeritus chair. What a rich experience Dr. Wexner has. He is a PhD, Fellow of American College of Surgeons, Fellow of Royal College of Surgeons, England, Edinburgh, Glasgow, Fellow of American Society of Colorectal Surgeons, and he has served as president of many of these member societies in the past. To share some of his research experience, he has close to 645 abstracts, close to astounding 1,000 manuscripts. He has authored 271 chapters in textbooks and has written 44 books. He is a recipient of 17 research awards and is an owner of 8 patents. He is the first surgeon in North America to popularize colonic J-pouch in rectal cancer. Please join me in welcoming Dr. Steven Wexner for today's webinar. We are grateful for his time and expertise, and we look forward to an informative and engaging discussion. Welcome, Dr. Wexner. Next slide, please. So the discussion today.
Thank you very much for the very kind introduction. I'm delighted to be here with you today. Always nice to be in India, even better to be in India in person, and looking forward to being there, I believe, 4 weeks from today at one of the surgical meetings.
We are looking forward to meet you, sir, in person too. So the discussion today is scheduled into 5 subtopics. The first one will be speaking about risk factors, then screening, diagnosis, treatment and management, followed by recent advances. So coming to risk factors, next slide. Dr. Wexner, can you enlighten us about what are the primary risk factors for colorectal cancer?
Yeah, so it's thought to be a healthy, basically a healthy lifestyle is thought to be preventative. Now, we'll get into later, I'm sure, genetics and family history and the interplay there, but let's assume someone does not have a family history or genetic predisposition. They do not have diseases that result in an increased risk of cancer, polyp syndromes, inflammatory bowel disease. The baseline risk tends to be related to eating processed red meats, to a lesser degree alcohol intake, tobacco intake, and seems to be somewhat lower in incidence in people who eat a lot of raw fruits and vegetables and grains, a lot of fiber. So I personally haven't eaten red meat since 1984, and which is one of the many reasons I love spending time in India. I can have a vegetarian diet, and I think that is healthy and preventative. And perhaps that's one of the reasons why the incidence, although the number of colon cancers in India is up there in the top 10 in the world, the incidence is amongst the lowest in the world per population, roughly about 1/6 the incidence to 1/8 the incidence of other countries with large numbers of colon cancers. And the reason for that is undoubtedly in some degree related to diet. Of course, genetics will play a role too. So at high absolute number due to the size of the population, but low incidence because of that diet and genetics.
So next question, Dr. Wexner, some you have already elaborated. Any specific lifestyle choices such as diet and exercise influence the risk of developing colorectal cancer? Can you stress on that a little more?
Yeah, I mean, the same things in terms of diet, having a lot of raw fruits and vegetables, a lot of unprocessed fiber is very, very healthy. Interestingly, those same dietary changes are good for the heart. And the reason I made my dietary change 42 years ago, I guess, was, or 40 years ago, was mostly for cardiac prevention, but it's the same for colon cancer and for diverticular disease. So that same high fiber diet, eliminating processed meats, red meats, is very helpful. Exercise is good to also help decrease the incidence of obesity. And there is a relation also, I didn't mention it, with obesity and colon cancer, with seemingly higher risk of colon cancer and obesity. So diet and exercise is in general good. It's good for mental health, it's good for physical health, it's good for the heart, it's good for the colon. And things that are good for the colon tend to be good for the heart and vice versa. So the sedentary lifestyle predisposes to all of these health problems, coronary artery disease, as well as colon cancer.
Thank you for answering that, Dr. Wexner. We are very happy to hear that you walk the talk and practicing a very healthy diet and exercise. Can we have the PowerPoint back, please? It's disappeared.
Yep, I was in the gym this morning before I came here, and I do Indian cuisine's perfect for me because I don't have to worry about eating meat.
So, how much amount of exercise and what type of exercise do you advocate to our audience? How many minutes per day, or how much amount of exercise?
Yeah, I don't think we have that degree of data for colon cancer. I don't think somebody knows it. You can read reports saying vigorous exercise 3 times a week for 30 minutes, or you can, minimum of 5,000 steps per day. I mean, there's a lot of things in the literature, but they tend to relate more to the heart than the colon. I'm not aware of data saying exactly how much exercise is a validated endpoint. Again, being active to some degree every day is helpful. Vigorous exercise, probably a minimum of 3 times a week. Whether that's cardiac, like being on a treadmill or an elliptical trainer or a Stairmaster, or running or jogging or cycling. Is that better than weightlifting and or yoga? I honestly don't know. It's just the idea of being active.
Right, Dr. Wexner. The next
question,
which
question though, for a research project.
Right. So a lot of patients come to us in our OPD and they ask, sir, we have a family member with a first degree relative, or a father or mother, uncle or aunt or grandparent having some colorectal cancer history. So I want to ask specifically for all these patients, can you discuss the genetic predisposition to colorectal cancer and how they are identified?
Yeah, I mean, if there's 1 or more first-degree relatives, the recommendation is to start screening 10 years younger than the youngest first-degree relative who had colon cancer. So first-degree relative would be a sibling, a parent, a child. If it's second-degree relatives, the risk isn't as high unless there are several second-degree relatives, aunts and uncles, cousins, things like that. So then, you need a higher number. But 10 years younger than the youngest. Now, if you think that the standard screening recommendation now starts at age 45 and somebody says, well, my brother had a colon cancer when he was 40, you should start getting screened at age 30. There's no doubt about that.
Right, Dr. Wexner. Anything you want to comment about some of the genetic syndromes, like,
Yeah, so right. So I alluded to that earlier. So there's a few conditions that predispose to a higher incidence of colon cancer. One is ulcerative colitis. I treat a lot of patients with ulcerative colitis, which is an inflammation of the entire colon that spares the small bowel. Now, fortunately, that incidence is lower than in other syndromes. Plus, patients with ulcerative colitis get screened and surveyed, both depending on what they've had. But they get looked at probably annually with pancolonic biopsy, so biopsies without the colon, and we can see precancerous change in more patients than we just see cancers crop up if the patient is getting properly screened on an annual basis. So those precancerous change can lead us to do surgery before cancer develops. Crohn's disease is the same, but also affects the small bowel, and the incidence of cancers in Crohn's disease is lower than in ulcerative colitis. So the bigger worry is ulcerative colitis, so both diseases have a predisposition. Then there are some genetic syndromes with polyps, because remember, most colon cancers develop from polyps. Most do not spontaneously occur. They're from polyps, which is the whole point of a screening colonoscopy, that if polyps are removed, they won't become cancers. And that's why one should undergo screening colonoscopies. Sadly, 50% or more of colon cancers are asymptomatic. Patients have no symptoms. They don't have rectal bleeding, they don't have change in bowel habits. Tumors are just found. So, getting back to that point, there are some syndromes like familial adenomatous polyposis. That's a syndrome where people have literally hundreds of polyps in the colon. It's a autosomal dominant gene, so 50% of the offspring of a patient with familial adenomatous polyposis will have familial adenomatous polyposis. And if that patient's diagnosed, then the colon should again be prophylactically removed with a reconstruction of a new rectum as a J pouch to prevent cancer. There are many other syndromes, familial syndrome, Lynch type syndromes, and attenuated polyposis. I mean, time will permit going into all of them. But it's important in those patients that genetic studies be done so you know who in your family is going to get it. Like in polyposis, these days, in the old days, we used to have to screen everyone. We look at the eyes because people have a pigment change in the eye. I don't want to get too deep into it at the moment. I'm sure we can talk about it more later. But the other point you mentioned about relatives with cancer, there's also concern if you have multiple relatives with things like breast cancer and GYN cancers, that those patients can also be at a higher risk, and attention should be paid. So it's not just colon cancers. There's a constellation of other cancers that relate.
Thank you for elucidating that, Dr. Wexner. I think because of your expertise, I think you already answered our next question, which I wanted to ask about role of inflammatory bowel diseases. So I'll skip that and go to the next question. How significant do you think is age as a risk factor for colorectal cancers? Because of late in the Indian community too, we're seeing a lot of younger patients in their 40s also turning up with colorectal cancers. So is age a specific risk factor? Yes.
Yes, globally, we're seeing a downward shift, which again could be a genetic drift, but also could be largely attributable to the Western diet. I mean, all over the world, you see the same in China, for example, where people used to eat a lot of rice and fish and other things, and now people are going to the local McDonald's and it's and having more processed meats than they would have in the past, and especially the young people, and that may be a factor as well. But we're seeing it globally. People not only in their 40s and their 30s, even occasionally in their 20s, coming in with colon cancers, far more often than when I started at Cleveland Clinic 36 years ago. I mean, far more often.
Thank you, Dr. Wexner. So we'll move on to our next subtopic for today is about screening for colorectal cancers. The first question I would like to ask you is, what are the most effective screening methods for early detection of colorectal cancer, and how does the screening help in prognosis of colorectal cancers?
Yeah, so there's a great question, and there's multiple ways of screening. One way is just in the office, having a couple of enemas and having a sigmoidoscopy, which is a instrument that will look up through the rectum and the sigmoid colon, but does not see the entirety of the colon. That has to be combined to be acceptable with something like a fecal occult blood test, looking for blood that you can't see in the stool, or a fecal immunohistochemistry test, which is more precise than the fecal occult blood test. So those are possible. The other screening method is colonoscopy, and that really is far more accurate than a sigmoidoscopy and fecal immunohistochemistry or sigmoidoscopy and fecal occult blood test. It really is the gold standard. And the advantage of a colonoscopy versus those other tests is if something is found, a polyp, remember that precursor lesion, the polyp, if it's found, it can be removed, or if it's too large to remove, it can be biopsied, whereas the other tests are really just diagnostic. They're in no way therapeutic or preventative of the cancer, whereas removing a polyp can potentially prevent a cancer.
Right, Dr. Wexner. Is there any specific size on the polyp which you would recommend removal, or any polyp on scopy we recommend for a removal? Which is the polyp which we can follow up?
Yeah. I mean, there are certain diminutive polyps, and these days with some of the advanced colonoscopy lighting techniques, you can not worry for a 1 or 2 millimeter diminutive polyp if you see that it's not adenomatous by narrow band imaging or some of the other techniques that the endoscopist can use. But in general, every polyp should be removed. I mean, if you see a polyp, it should be removed. The only reason not to remove a polyp if it's too large or unsafe to remove.
Right. So next question I would want to ask is, at what age do you recommend individuals begin regular screening for colorectal cancers? And do you really think it is cost effective to screen an entire community for colorectal cancer?
It is very cost effective because the cost of people presenting with late cancers, with obstructions and perforations, the cost of treating metastatic disease starts to get exorbitant compared to the cost of a screening colonoscopy, which in some parts of the world are not even performed by physicians and surgeons, performed by nurse practitioners and physician's assistants who are trained to do colonoscopy. Again, that's an exception. Usually it's performed by a gastroenterologist, colorectal surgeon, or general surgeon. But it is cost effective, and it should be done. Again, the recommendations from virtually every society, is, at least in the US, is to start at age 45. But in many cases, family history and others start younger. The general guidelines age 45, which probably 7, 8 years ago, 6 years ago, changed from age 50. It was lowered because of what you mentioned earlier, having an increasing incidence in younger people.
Right. So dear listeners and audience who are listening to us today, please don't fear for getting a screening test for colorectal cancer. It is very, very safe, and it's very much cost effective. Remember, the cost of a screening test is much lower than facing a colorectal disease with advanced cancer. So
if I might just say, colon cancer is literally the only cancer that is preventable in most people, right? If you show up with a lump in the breast and it's known on mammogram, ultrasound, MRI, you felt it, it's cancer, it's not cancer. If you have a spot on your lung in a chest x-ray, it's cancer, it's not cancer. If you have a lesion in the skin, it's a melanoma, it's not. Colon, you can have a pre-cancerous growth removed and it won't become a cancer. So, the logic defies me in people who don't want to have a colonoscopy. Granted, the bowel prep is miserable, but okay, fine. It's more miserable having a colon cancer and showing up that it's spread to your liver and your lungs.
Very, very aptly put, Dr. Wexner.
Right.
The next question I want to ask, can you explain the specific differences between what a colonoscopy and a sigmoidoscopy is, the length of screening, and the fecal occult blood test too? How does it differ from the scopies in colorectal cancer screening?
Yeah, so the colonoscopy is the most accurate and precise test, and also allows for sampling of the tissue, biopsy, or complete removal of the tissue, polypectomy, polyp removal, and thus not only diagnosing but preventing precancerous or preventing cancers by removing precancerous growth. The colonoscopy allows you to look through the entirety of the colon. Sigmoidoscopy only allows you to look at the end, perhaps as many as 60 centimeters of the rectum, the sigmoid colon, and a bit of the left colon, maybe up to the splenic flexure on the left side. But that still leaves out more or less 2/3 of the colon, the transverse colon and the right colon. The colonoscopy captures it. So a sigmoidoscopy is not a substitute for colonoscopy. Now, sigmoidoscopy plus fecal immunohistochemistry or fecal occult blood is an accepted alternative, but the problem is the fecal occult blood test has a lot of false negatives. Fecal immunohistochemistry has some false negatives, but they both have false positives as well. So you end up getting the test and then still needing a colonoscopy and finding there's nothing there. So that concerns me less, getting a colonoscopy and finding that it was a false positive, than missing something in a false negative. And we all, I'm sure you do too, you see stories like this. Somebody, but I had a fecal occult blood test last year and I have this whacking great hepatic flexure cancer. Okay, well, the fecal occult was a false negative. There's also CT colonography, by the way, which is a kind of CAT scan test where the colon is filled with air and you can look for growths. Again, it's not as accurate as colonoscopy. You can have false positives, bits of stool that the radiologist thinks a polyp, but it's not. And you can certainly also have false negatives, more likely false positives. But again, if you see something on a CT colonography, you still need a colonoscopy to deal with it. So again, I think just go straight to colonoscopy personally. Now, it's resource, particularly in India. Are there enough people to truly screen the entirety of the population? Probably not, but it would be ideal if everyone were screened according to guidelines.
Right, Dr. Wexner. The next question, I think, is probably someone who has experienced this horrible bowel preparation is asking this. Is there any non-invasive screening technique that he or she can do to omit this colonoscopy, which they think is invasive? Is there a blood test or a fecal test which you think can replace this colonoscopy or
Well, to my knowledge, there's no blood test yet that's screening for colon cancer. Particularly since you'd really have to have a blood test that screens for polyps. What we do have are the things I've mentioned: fecal occult blood, fecal immunohistochemistry, and CT colonography using a CAT scan. Those are the non-invasive modalities.
Right, Dr. Wexner. Let us move ahead with our next subtopic about diagnosis of colorectal cancers. So what are the typical symptoms that might prompt for a patient, to see a doctor thinking that he or she has colon cancer, when he should suspect and see an expert immediately?
So here's the problem with symptoms. Like, more than 50% of patients don't have symptoms. And so, you don't wait for symptoms to present. And that's typical. We see that in patients all the time. There are certain exceptions. In the rectum, a large cancer might cause a sense of urgency in the patient needing to go to the toilet to open their bowels more than they used to. So certainly change in bowel habits, that somebody's gone from once a day to 4 times a day, or the bowel habits have become irregular, or they're becoming progressively constipated, or they're noting blood, or the stool's changing to very dark, like old blood in the stool. I mean, those are symptoms one can get. And you can have abdominal pain, certainly, but again, these tend to be with more advanced lesions. And I think the reason that the treatment, the diagnosis and treatment of colon cancer in young patients is so challenging is many of these patients, the younger patients in their 30s, 40s, but particularly in their 30s, present with advanced tumors. They've already have secondary lesions in the liver and the lungs. Why? Because they presented with rectal bleeding, and the GP. So firstly, the patient says, "Oh, it's just hemorrhoids," and then they go to the GP, and the GP says, "Oh, it's just hemorrhoids. Soak your bottom in a tub, take some more fiber, take some ointments, whatever." And everybody ascribes it to hemorrhoids. And then finally, it turns out, no, it's actually a tumor, which is very progressed. So particularly in young people, if there's not some very obvious source for that bleeding during office exam of the anus, they get a colonoscopy.
Thank you, Dr. Wexner. Next question I want to ask, there are many imaging modalities from ultrasound, MRI, CT scan, CAT scan, PET scan, Ameerpet. So how do you think the imaging technology has improved the diagnosis of colorectal cancer?
Yeah, well, for diagnosis, it really hasn't, because they're not screening tools. But once the patient is found to have colon cancer, they've tremendously improved. So, PET scan will let us see, and not everybody needs every test, but a PET scan will let us see if there's any secondary lesions elsewhere. The CAT scan is also used, but the CAT scan needs to be the chest and the abdomen and the pelvis, and those are helpful. And the MRI is really reserved for rectal cancer, which is a special circumstance, where a lot of decisions are made for the treatment of rectal cancer based on the depth of the tumor through the layers of the rectum, and that's not true for the colon. Right? So typically for a patient with rectal cancer, we would get an MRI of the rectum, very specific protocol, thin slice, to look not only at depth of penetration, but for certain features that might dictate an approach, like are the lymphatics involved, are the blood vessels involved, things like that, is the edge, the deepest part, likely to potentially be compromised during surgery. These things can warrant chemotherapy and radiation first. That's not true in the colon.
Right, Dr. Wexner. So next question I want to ask is, can you discuss the role of biomarkers in the diagnosis or prognosis of colorectal cancers?
Well, the biomarkers, again, the genetic signatures are more for patients. It's not a general public screening tool yet. Hopefully one day it will be. But it is useful in patients with a family history. Plus, there's always a proband. So somebody's the first in every family, right? So when we see a patient who's 30 years old with a cancer, we send them to the geneticist because we want to know what's going on here, and are they the proband in a family to have this problem, and then they need to know so they can counsel their spouse or spouse-to-be or whatever, know about screening their children. The biomarkers are helpful for prognosis in everyone. It can help for the medical oncologist know which kind of chemotherapy to give, to know whether immunotherapy is appropriate for the patient. There are some tumors now, roughly 7% of the colon cancer population, so it's not a big number yet, but where the tumor will melt away with immunotherapy and the patient doesn't need surgery. In around a third of patients with rectal cancer, either chemotherapy alone or chemotherapy and radiation may be able to result in complete eradication of the tumor and avoid surgery. So that's where the biomarkers help to guide the treatment more than the diagnosis.
Right, Dr. Wexner. So I want to ask, how do you approach the differential diagnosis of colorectal cancers to rule out other conditions? When do you think you should investigate more with someone with bleeding per rectum, and when we can think hemorrhoids, or what are the DDs that can come up in treatment of colorectal cancers?
Right. So I think in this day and age, with the increasing incidence of colorectal cancer globally, as I mentioned earlier, if somebody has an obvious source of bleeding and they're telling me it's bright red rectal bleeding and they have no family history and no personal history of colorectal cancer or polyps, and they come in and they have a big bleeding hemorrhoid, I'm not necessarily going to subject that 30-year-old patient to a colonoscopy. On the other hand, if the hemorrhoids are just slightly enlarged, I don't see them actively bleeding, that patient's going to get a colonoscopy. Patients who are in the screening population age, 45 and over, those patients I would again look at the bottom and I ask when was the last colonoscopy, and the guideline is every 5 to 10 years in the absence of family history or polyps. But I'd have a very low threshold to send that patient back for colonoscopy in the absence of finding anything to which I could definitively attribute the bleeding during my office exam.
Right, Dr. Wexner. Thank you for answering that. We'll move on to our next subset of questions on treatment and management. So what are the current standard treatment options for colorectal cancer?
So the standard treatment for, again, divide colon and rectum because there really is a big difference. So for colon, it's surgery. There are some patients you wouldn't do surgery. So if a patient comes in with disease that's already spread to the liver, you might consider chemotherapy first if the tumor is not causing a blockage. It's not an emergency situation. That patient may first undergo chemotherapy. Ditto if it's spread to the lungs. But in general, in the absence of spread of the cancer to other organs, surgery is going to be what's done first. That paradigm is slowly changing, and there may be more patients getting chemotherapy in advance of surgery, as is the case of rectum. And depending upon the genetics of the tumor, there may be some patients who get immunotherapy and don't end up needing surgery at all. And Memorial Sloan Kettering published on this. It's only a handful of patients, but then 100% resolution of the tumor with no need for surgery in that small group of patients. So now rectal cancer is different because rectal cancer, the rectum is a different organ in a way than the colon in that it's housed in the bony confines of the pelvis and the anal muscles are there. So for the colon, you can remove any section, put the ends back together, and Bob's your uncle. For the rectum, if the tumor is very low down, taking out the tumor may entail taking out the anal muscles and therefore having a permanent colostomy bag. Obviously, you want to avoid that. In addition, there's plenty of room around the colon to take it. In the rectum, in the confines between the backbone and the bladder, the prostate, the uterus, all of this, the pelvis, there's not a lot of room. And what that means is if the tumor is deeply penetrating and you do surgery and you're too close to the tumor in surgery, quite honestly, because the tumor is against bone or anything else, that patient has a high incidence of recurrence. So that's why chemotherapy and radiation therapy are used prior to surgery. There's some evidence that chemotherapy alone can do the same job as chemotherapy and radiation. And that therapy used to be done prior to surgery in patients at high risk of local recurrence, judged by MRI imaging. But now, roughly a third of those patients, the tumor will disappear. And the patient may elect not to have surgery, and we watch that patient and survey that patient. Patients in whom the preoperative MRI imaging shows that surgery should be completely curative without any, they don't have any of these adverse signs like invasions of the lymphatic or the blood vessel or the tumor being close to where you're going to be cutting the margin, they can go straight directly to surgery.
Right, Dr. Wexner. So how has minimally invasive surgery impacted the treatment outcomes for colorectal cancer patients?
So I'm very proud that I started doing laparoscopic colorectal surgery back in 1991, 33 years ago. I was one of the first in the world to really champion doing this operations, first for benign disease and then for malignancy, for cancer. And the reason it added so much is that short-term, less pain because there's little punctures and a small incision or no incision as opposed to big incision. Less suppression of the immune system, so patients are having better outcomes for recovery. Even some evidence better outcomes for tumor recovery, for cancer survival in some studies, though not in all studies. Long-term, less incidence of bowel blockages from scar tissue, less incidences of hernias needing to be repaired. So all around minimally invasive surgery conferring huge outcome benefits to patients, from shorter hospitalization and less pain to better quality of life sooner and the like. It's become, since around 2000, and more so starting around 2010, that people use the robot instead of the laparoscope. So far, there's really no evidence that one is better than the other, but they're both better than a big incision.
Right, Dr. Wexner. I think you commented about this already, about the role of chemotherapy and radiation therapy in colorectal cancers. I would specifically want to ask, which are those patients whom you would allow a wait and watch response after, complete response after chemo radiation, and which patients you do not want to wait and go ahead and perform a surgery even if there is a complete response?
It's shared decision making. It used to be, as the surgeon, you told the patient, this is what you're going to do, or the patient would ask, say, you just tell me what I'm doing. But more and more, it's shared decision making with the patient's family, as well as with the entire multidisciplinary team. Some patients feel better knowing it's out, even if we don't see anything on imaging. And by the way, patients who are candidates to wait and watch are patients in whom there's no tumor noted when you look with a sigmoidoscope or kaleidoscope, when you feel with your finger, and when you image with MRI. So there's no evidence of tumor by any of those tests. Then you can have the discussion with the patient. If surgery entails removing the anal muscles and having a colostomy, very few patients are going to opt for surgery. They'll say, no, I'd rather wait and watch and be screened, surveyed rather. On the other hand, if the tumor is higher up and it won't require a colostomy, some patients feel better. Not most. Most would prefer to wait and watch. The problem is the other direction, that patients have heard about wait and watch, and patients who do not have a complete response say, well, I don't want surgery. And you show them, say, look, on endoscopy, there's this irregular area here, or on the MRI, it appears there's something, and they refuse to have surgery. And that's a sad situation because those tumors keep growing, and those patients do not do well.
So do you anytime do a biopsy from such areas or in your waiting?
If there's something abnormal and the patient is not agreeing to surgery, absolutely. If the patient it says, yeah, I agree, it doesn't belong there, it's not a complete response, then I don't need to biopsy if they're going to have surgery. The problem becomes when there's something abnormal there and you biopsy it and it doesn't show invasive cancer, but it shows precancerous change, what's called dysplasia, and the patient, or adenoma, which is polyp. And the patient says, yeah, but it doesn't show cancer. I mean, there are patients like that. You say, but dysplasia, adenoma, there's cancer. We just didn't sample that. We took the whole thing out, wasn't there? And the problem is there can be foci of tumor cells outside of that little area, like in the fat around the rectum. And the patient gets a false sense of security. So the only role biopsy serves is to convince somebody who doesn't want surgery that they need it.
Right, Dr. Wexner. One important question I want to ask is, especially in the Indian subcontinent, there's a lot of stigma, especially around a permanent stoma. So how does stoma impact the quality of life of patients post colorectal surgery?
Well, number one, fortunately, there are a lot of techniques to avoid stomas, reconstructing the rectum, even right down to the skin at the bottom, as long as the muscles or most of the muscles are preserved. But there still are patients in whom the tumor is invading the muscles and colostomy is necessary. So the first thing to realize is in those patients, the choice is life and death. So if a colostomy may be distasteful, they don't want to have it, social stigma against it. If they don't have surgery, they're going to die from the tumor. So that's the starting point of the conversation. It's life or death. If they choose life, one of the things that I like to do with my patients is have them meet with not only the stoma therapist, but network with other patients with colostomies and the United Ostomy Association group or others and learn about it. And the thing that I think helps patients is when they can irrigate the colostomy. So they know they don't have to wear an appliance, a bag outside. They can essentially like giving themselves an enema, but as opposed to doing it through the bottom, it's through the colostomy. And they can train their colon to empty certain times of the day. And it makes it, patients usually when they hear that, they're a bit better. They say, oh, I can cover it with a gauze square instead of having to wear a bag. Yes.
Right, Dr. Wexner. One question, since we are especially discussing about low rectal cancers, is what I want to ask, especially when treating with something like a coloidal anastomosis or intersphincteric resections. How do patients with these surgeries fare post-operatively, especially in terms of large core and continence issues? And what are your techniques and advice for surgeons, young surgeons, listening to you about improving the large scores?
Well, for one thing, that's true. So just to back up, the rectum is a unique organ which stretches. So as I explained to my patients, it's like a balloon, right? You can fill it and then empty at an appropriate time. The colon is more like a conduit, like a pipe. So when you remove the rectum and you substitute the colon, it doesn't stretch the same. It doesn't have, it just, the stool wants to go through it. And that's the low anterior section syndrome. The patients have to go multiple times. They don't completely empty. The peristalsis, the contraction of the colon, isn't the same as the rectum, the coordinated muscles. So it's never going to be the same as it once was. Again, patients would, at least they think, they would prefer that kind of a lifestyle to a colostomy. Some patients do ask for colostomy eventually because they're fed up with having the low anterior section syndrome. But unfortunately, the majority of patients in whom we do these reconstructions do get at least some degree of clustering of bowel movements, urgency, irregular bowel habits, maybe even some accidents. And those are things they have to be counseled about. Now, there are some treatments like, again, enemas try to keep the rectum empty, pelvic floor retraining, trying to learn the signals and strengthen the muscles where possible. We as surgeons can employ certain techniques. One is the colonic J pouch, which I'm a strong believer whenever the patient has adequate length to reconstruct a larger rectal reservoir. So rather than bringing the colon straight on, if you bend it on itself, you have a double width and you can create a little bit of a pouch there about 8 centimeters long, and it's a better reservoir. It's been proven in our randomized controlled trial of around 100 people and in others that at least for the first 1 to 2 years, the patient has significantly fewer bowel movements. Long term, it about evens out. So it is something about which we counsel the patients prior to surgery. But again, their focus, as you yourself said a little earlier, they're focused on avoiding a colostomy. So when you say you're going to have this clustering and urgency and maybe some accents or regular bowel, I was like, fine, I'll take that. I just don't want the colostomy.
Right, Dr. Wexner. One question which I want to ask, especially I think there have been some rounds in the media about use of immunotherapy and patients not needing surgery, and some patients do ask us in the OPD about, they come to us and say, doctor, why don't you give us some immunotherapy and we can avoid surgery? I've read that there is a 100% response and the tumor has disappeared. So especially for these patients, I'm asking, what are the latest advances in targeted therapy and immunotherapy for colorectal cancers? Can they substitute surgery and eliminate surgery totally?
Yeah, so we spoke about this a little bit. It's roughly 7% of the population would fall into what to what the Memorial Sloan Kettering group showed us, that in patients, and it has to do with something called microsatellite, stable versus unstable. And in that group of patients, and in this day and age, we do test all tumors to see microsatellite status and a lot of other genetic signature things. And in that group of patients, there are potential candidates. But unfortunately, it's only 7% at present. And that's the thing, the patient needs to most know, that, listen, yes, your, immunotherapy works, but, you may not be in that group. So usually, since the patients get these things when they're screened, we as surgeons have that information by the time we meet the patient. And we tell them, no, you're not a candidate, or you are a candidate.
Right, Dr. Wexner. One question especially I wanted to ask is whether there's a colon or a rectal lesion with liver metastasis, which is also resectable. What is your approach? You resect them simultaneously, you go for upfront chemotherapy, or you a stage procedure? How do you approach these patients?
It's dependent on the discussion in the multidisciplinary team conference. So every newly diagnosed patient with colon cancer, rectal cancer, we discuss at our multidisciplinary conference, and that's what I tell the patient is the wisdom of the crowd. I say, listen, I may be, the most senior people anywhere around this area for doing a senior person doing this, and maybe I have the highest volume, but I don't know everything. So we're going to get the opinions of our medical oncologists, our radiation oncologists, our pathologists, our radiologists, other surgeons, geneticists, in this case, the liver surgeons. And we're going to make a group decision. What's best? Is it best to have chemotherapy and treat the liver lesions and then go for the colon? Is it best to do the colon first? Is it best to do both at the same time? Certain circumstances will mitigate one way or the other. If it's a colon cancer that's from which the patient's losing blood and needing transfusions, if it's a colon cancer there's an imminent danger of blockage, those patients for sure are going to get the colon done first. But most patients, fortunately, are not in that situation. And then it often becomes chemotherapy and then liver and colon at the same time, or chemotherapy, colon, and then liver. It's individualized. It's tailored to the patient through the multidisciplinary team.
Thank you, Dr. Wexner. That's very brilliantly put up.
Thank you.
So next treatment questions is about some management, post-surgery also. What are the key components of post-treatment management for colorectal cancer survivors?
Well, it used to be potentially giving chemotherapy, but for rectal cancer. For rectal cancer now, the chemotherapy is pretty much in everyone delivered up front. Colon cancer is still an area where, because neoadjuvant or pre-surgical chemotherapy isn't really being used as much as in rectum, where that patient might get adjuvant. So the first post-treatment management may be chemotherapy for some period of time. And then the other thing that's important to remember is that patient needs to get another colonoscopy, because one of the highest risk factors for colon cancer is a history of a colon cancer in the same patient. So patients had one cancer, they may get a second one. And continued surveillance with colonoscopy starting 1 year after surgery is important. And imaging. periodic imaging too, by the way. I mean, following a CAT scan or PET scan in these patients, and for rectal cancer, also getting an MRI and doing a digital exam.
Right, Dr. So I want to ask about the next question. I think you have also spoken about monitoring for recurrence about the scans. What lifestyle changes do you recommend for patients after treatment to reduce the risk of recurrence?
I don't know that one can reduce the risk. It's sort of the old expression, the horse is already out of the barn. By the time somebody gets a cancer, they've already done whatever it is to their immune and genetic system by their lifestyle. So you can be more active, you can change your diet. I'm not sure it makes a difference at that point. The one thing they can do to reduce the risk of recurrence is not so much recurrence, but another cancer, metachronous cancer, is get their screening colonoscopy. Preventing recurrence isn't so simple, but early detection of recurrence when it's at a stage when it's treatable for cure is important, and that's where it comes in to do these studies, as I mentioned, to go ahead and routinely do the MRI of the pelvis in the rectal cancer patient, the chest, abdomen, pelvis from the CAT scan, maybe a PET scan, the carcinoma embryonic antigen, the CEA blood test. That's important.
Right, Dr. Wexner. So how do you manage the long-term side effects of these cancer treatments?
The long-term side effects.
Post-treatment. Long-term.
Again, this is more for the medical oncologist. For us, we already discussed a little bit on how we manage low anterior section syndrome. This one's really for the medical oncologists, and patients can have neuropathy. Patients can have they can have their blood counts drop low and due to suppression. So the medical oncologists monitor patients and, of course, talk to the patients, just like we do. When I talk to somebody about surgery and I say, well, risks of this operation are injuring another structure, your spleen, your urine-carrying structures, maybe the nerves for sexual function, it's talking. And the medical oncologists do the same. They say, if we do FOLFOX versus FOLFIR, your risk is neuropathy, or your risk is immune suppression, or whatever it is.
Right, Dr. Wexner. Next question, I think we already discussed on the multidisciplinary approach in the management of colorectal cancers. Maybe anything in the future whom you want to see to join the multidisciplinary team, apart from the existing geneticists, pathologists, medical oncologists, radiation oncologists?
No, we have a very robust participation in our MDT, and in part that's due to the National Accreditation Program for Rectal Cancer, which I'm thrilled to participate in that NAPRC. In fact, that I helped create it. I still remain the founding chair of that program. So I'm thrilled that I can do that. And we do include everyone there, and it's mandatory that all of those different specialties, well, not the geneticist or the liver surgeon or the spine surgeon, we call them individually, but it's mandatory that the surgeons, medical oncologists, radiation oncologists, pathologists, radiologists, they're all there at every single MDT that every patient's discussed for rectal cancer, and that we meet a minimum of every other week. In fact, we meet weekly because of the volume of patients we have. I saw for our Monday agenda, we have 15 patients we're discussing.
Right, Dr. Wexner. Coming to our last subtopic for discussion today about the latest advances in colorectal cancer treatment. What are the most exciting recent developments in colorectal cancer research you think about?
Well, I think, the in terms of an individual advance, I think probably over the years, if we look at what we have, it's clinical research, it's not bench research, and that's firstly going back to the 1970s, the advent of colonoscopy, and then fast forwarding after that into the maybe the 2000s, MRI for diagnosis. All of these things are very important. On the bench side is probably more the immunotherapy. Firstly, total neoadjuvant therapy, which leads to wait and watch, and then immunotherapy. I think those are the things that are important.
Right, Dr. Wexner. Anything specifically about promising therapies or surgical techniques currently in clinical trials you want to discuss about?
Well, I think we're going to find more and more types of immunotherapy that work for more and more tumor types. And I think over the years, we're going to find less people needing cancer because we're able to satisfactorily treat those lesions with immunotherapy.
Right, Dr. Wexner. How do you see the future of colorectal cancer prevention, diagnosis, and treatment evolving in the next decade?
I think that I hope that more people, like you're doing today, more of the public become aware of the importance of screening and get screened. And so the incidence goes down, that precancerous growths are removed. That's the first thing I hope. The second thing I think is more people having access to care through a multidisciplinary team and not through an individual practitioner. And then the third is more people having access to minimally invasive surgery and the benefits it confers.
Thank you, Dr. Wexner. I think you have answered all of our queries. I think most audience questions also have been discussed in great detail because we pulled in a lot of audience questions for the upcoming webinar and we have put you in the structure format of discussion. We have a very exciting Grace Cancer Run, the 7th edition that is coming up in October as a awareness for the general public, the importance of exercise and a healthy lifestyle. We do this run every year and this exciting webinar series to bring about awareness on cancer prevention.
Great.
So we thank you, Dr. Wexner, for joining us today. Audience has learned a lot of information about cancer screening and cancer prevention, what are the risk factors in great detail, what to be watchful about. The young surgeons have learned a lot about how do you manage cancer patients. We thank you very much for joining us today, and we'd like to bring this webinar to an end. We welcome all our audience to join us for the exciting Grace Cancer Run in October month. Thank you very much, Dr. Wexner.
Thank you very much. Take care. Have a good evening. Bye. I'll see you in Chennai next month.
I'll try to join you in person, Dr. Wexner. Thank you so much. This is your host, Dr. Harish, signing off. Thank you very much.
Harish?
So I think we are still live.
Yeah, I think no. I think let me thank the host and the chief guest for today's webinar, Dr. Wexner. Thank you so much for your valuable time, and you have really enlightened us. Appreciate that. And for all the viewers, again, the call is very simple and loud. Even as we discussed through today's webinar, prevention is very essential, and Grace Cancer Run is a step towards healthy lifestyle to combat cancer. So come. Join us on October 6th, wherever you are, both virtual and in person. In Hyderabad, it's happening in Gachibowli Stadium. You have a 2K, 5K, and a 10K available. Please come, join us, and be part of the global revolution that we are bringing to alleviate the cancer burden across the world. So look forward to see you all. You can register yourself at gracecancerrun.com or gracecancerfoundation.org, and look forward to see you all at the starting line. Thank you so much.
Thank you, sir. Thank you, Dr. Chinababu, for joining us.
Thank you. Thank you, Harish.
Thank you, Harish.